Tuberculous abscess complication. Background. Tubercular abscess of the chest wall is a very rare disease. 5 articles have reported on it and those that have enrolled 5 patients. To determine the characteristics of this disease and to suggest an optimal treatment strategy, we review patients treated with surgical management. The diagnosis of tubercular abscess of the chest wall is difficult and often diagnosed by postoperative pathology examination. Preoperatively, it can be confirmed by detecting acid fats, bacilli, polymerase, chain reaction, or culture of pus in the abscess. Many authors recommend nailing aspiration or incisional biopsy to confirm the tubercular disease or the exclusive other inflammatory disease.
This is a 17-year-long presented with large swelling right side of the neck for 4 months. She has history of chronic cough, low-grade fever, and with approximate weight loss of around 5%. There is a soft globular swelling of size around 8 cm into 7 cm into 6 cm occupying the right side of the neck. This is cystic in consistency. Skin over the swelling is normal without redness. There is fluctuation present. This is non-tender. The swelling doesn't increase with coughing or not moving with deglutition. This is diagnosed as cold abscess right side of the neck, which was confirmed with FNAC. This patient needs incision and drainage and evacuation of the pus as the collection is used and occupying almost a large part of the right side of the neck.
Although its historical significance is well established, Mycobacterium tuberculosis today is considered an extremely rare cause of pus abscess.
This is a case of tuberculous neck abscess. The patient is a young male, about 25 years old, presented with a swelling over the lower part of the neck. This is the swelling, just about the clavicle, supraclavicular area. Swelling was not tender. The skin over the swelling was normal. Patient did not have many of the acute inflammatory symptoms. On examination, the swelling was soft, fluctuating, and that revealed underlying fluid.
Not a tuberculous bacteria infection, most commonly secondary to an intra-abdominal process, but at the time operating. Without an identifiable source, is responsible for the vast majority of both abscesses.
Hi friends, here this is the thigh region of the candidate, and there was a quite big swelling was present over there. It was a firm inconsistency, and when aspirated we found a pus over there, but there was no signs of any inflammation, and so such kind of abscess is known as cold abscess, where the signs of inflammation are absent, and if painful can be due to the pressure when the abscess and the pus exert the pressure on the surrounding area. So such abscesses are usually seen with the tuberculosis. You can make the diagnosis under ultrasonography as well as CT scan, and MRI is also advantageous.
With the result, it is recommended that the diagnosis can be made without a preparative bacteriologic examination in geographic areas where the prevalence of tuberculosis remains high. Instead, it can be clinically diagnosed with the clinical feature of the chest wall abscess, history of pulmonary tuberculosis, and typical CT findings. Post-operative medical treatment is mandatory for an acceptable cure rate. The duration of anti-tuberculosis therapy is controversial, but a minimum of 6 to 9 months of isoniazid and rifampicin based therapy will be needed. Pike et al. Suggested medication for a minimum of 12 months, especially in endemic geographical areas. Thank you.